This lecture will continue on with Chapter 18, Depressants, starting on page 239, Anesthetics. Anesthetics are classified as general or local. General anesthetics depress the CNS, alleviate pain, and cause a loss of consciousness. The first anesthetic was nitrous oxide or laughing gas. Local anesthetics block pain at the site where the drug is administered by preventing conduction of nerve impulses. So pain relief is limited to a certain area. Different routes for anesthetics include inhalation, IV, topical, local, and spinal, and we'll talk about all those different routes going forward. Balanced anesthesia is a term, an idea that you need to be familiar with, because when a patient's being put under for a surgical procedure or whatever it might be, it's not like they get one large dose of a medication, of an anesthetic that is used to treat them. So a lot of times they get a balance, they receive balanced anesthesia, so multiple different medications. Balanced anesthesia is a combination of drugs frequently used in general anesthesia. So it can include a hypnotic given the night before, pre-medication with opioid analgesic or benzodiazepine plus an anticholinergic given about 1 hour before surgery to decrease secretions. And again, you have there, so your benzodiazepine listed on your slide is midazolam. You see the LAM. You should immediately be thinking that's a benzodiazepine. Anticholinergic, we've already talked about atropine. Something goes up, something goes down. What goes down? Secretions. Salvation is used pre-op to decrease secretions. Third thing, a short-acting non-barbiturate, such as propofol. 4, an inhaled gas, often a combination of inhalation anesthetic, nitrous oxide, and oxygen. And then 5, a muscle relaxant given as needed. And so the purpose of blended or balanced anesthesia is something you need to understand. It's used, so the combination of all these different drugs is used because it minimizes cardiovascular problems, decreases the amount of general anesthetic needed, reduces post-op nausea and vomiting, minimizes the disturbance of organ function, and decreases pain. Because the patient does not receive larger doses of general anesthetics, fewer adverse reactions occur, and recovery is enhanced by allowing quicker mobility, which is important post-op. The stages of general anesthesia you can find on table 18.4 on page 240. It starts with analgesia, begins with consciousness, and ends with loss of consciousness. Speech is difficult. Sensations of smell and pain are lost. Dreams and auditory and visual hallucinations may occur. This stage may also be called the induction stage. Stage 2 is excitement or delirium. Produces a loss of consciousness caused by depression of the cerebral cortex. Confusion, excitement, or delirium occur, and induction time is short. Stage 3 is surgical. Surgical procedure is performed during the stage. There are 4 phases. Surgery is usually performed in phase 2 and the upper phase 3. As anesthesia deepens, respirations become shallower and the respiratory rate is increased. Then finally, stage 4 is medullary paralysis, a toxic stage of anesthesia in which respirations are lost and circulatory collapse occurs. Ventilatory assistance would be necessary. So first we're going to talk about inhalation anesthetics. Inhalation anesthetics are listed in table 18.5 on page 241. If you look, a lot of them have the ending A-N-E, so just recognize that A-N-E is being indicative of an inhalation anesthetic. And then also nitrous oxide, obviously laughing gas, you'd want to recognize as an inhalation anesthetic. Inhalation anesthetics provide for smooth induction. They're usually combined with other medications, non-barbiturate, such as propofol, strong analgesics, such as morphine, paralytic, such as pancuronium. Adverse effects, respiratory depression, hypotension, dysrhythmias, hepatic dysfunction, and malignant hyperthermia. If you're not familiar with malignant hyperthermia, go ahead and look up that term so that you're somewhat familiar with it going forward. Consciousness usually occurs minutes to an hour upon discontinuation of the inhalation anesthetic. IV anesthetics may be used for general anesthesia or for the induction stage of anesthesia. Propofol, etomidate, and ketamine are at the bottom of table 18.5 on 241. I want you to be familiar with those. So etomidate, ketamine, and propofol, I want you to recognize as IV anesthetics. Midazolam and propofol are commonly administered for the induction and maintenance of anesthesia or for conscious sedation for minor surgery or procedures like intubation and mechanical ventilation. Adverse effects from IV anesthetics include respiratory and cardiovascular depression. The use of topical anesthetic agents is limited to mucous membranes, broken or unbroken skin surfaces, and burns. They come in different types of forms and are applied topically. They decrease the sensitivity of nerve endings of the affected area. Local anesthetics work by blocking pain at the site where the drug is administered by preventing conduction of nerve impulses. So if you think about someone who maybe cut their hand deep and they need to come in and get some sutures, when the provider would use lidocaine to numb up the area, that would be considered a local anesthetic because it's just that small area that's being numbed up. They're useful in dental procedures, suturing skin lacerations. They can be used for short-term or minor surgery at a localized site. Can be used for nerve blocks and diagnostic procedures such as lumbar punctures and thoracentesis. Let's see. I'm not worried about, in the two different groups here. What I do want you to recognize, if you look at table 18.6 on page 242, lidocaine would be your prototype local anesthetic I want you to be familiar with. But then just looking at the endings of those medications, CAINE, like the ending of lidocaine, should give you a clue that you're dealing with a local anesthetic. Spinal anesthesia requires that a local anesthetic be injected into the subarachnoid space below the first lumbar space in adults and the third lumbar space in children. Some side effects or adverse effects that we're worried about: if the anesthetic is given or spreads too high in the spinal column, the respiratory muscle could be affected, and respiratory distress or respiratory failure could occur. A post-dural puncture headache may result from spinal anesthesia. Sometimes you'll hear people talk about a spinal headache. It's possibly caused by a decrease in cerebrospinal fluid pressure caused by a leak of fluid at the needle insertion point. It's important that you know patient teaching for a patient who's experiencing a spinal headache. We want to encourage the patients to remain flat following surgery with spinal anesthesia and to take increased fluids because they usually decrease the likelihood of leaking spinal fluid. Headaches occur more frequently in females and in younger patients. OB patients have the highest incidence. Hypotension can result following spinal anesthesia due to the ensuing sympathetic blockade and predisposing factors that include sensory block location, history of hypertension, and chronic alcohol intake. The next, if I can get it to go, there you go. The next slide there lists some different types or various sites where nerve blocks can be performed with local anesthetic. I'm going to let you look over those on your own. When you're done with that, go to your nursing process box for anesthetics on 244, pause the video, and pull out what you think is most important. In terms of assessment, we're going to assess baseline vital signs, get a drug and health history, noting any drugs that affect the cardiopulmonary system. Nursing diagnosis, we're worried about pain and breathing pattern. For planning, we expect the patient will participate in pre-op preparation and understand post-op care, and patients' vitals are expected to remain stable during and following surgery. In terms of nursing interventions, monitor the post-op state of sensorium or level of consciousness. Report if a patient remains excessively non-responsive or confused. We want to monitor pre- and post-op urine output. So that's a big thing a lot of students are familiar with, needing to get the patient up and walking post-op. But another thing is monitoring, encouraging them to try to void and monitoring when they void and how much. We want to monitor vital signs following general and local anesthesia. Hypotension and respiratory depression may occur. So those are big things that you need to monitor. on these patients who are receiving these medications. Hypotension and respiratory depressions are big concerns that we're going to be watching for. Administration of an analgesic or a narcotic analgesic with caution until the patient fully recovers from the anesthetic. To prevent adverse reactions, the dose might need to be adjusted if the patient is under the influence of an anesthetic. So again, we're just worried about too much depression occurring in the patient. So we're going to go forward now to the end of the chapter questions. I'll read them. You can pause it and try to figure it out on your own before you hear the answers. Which nursing intervention would be most appropriate for the patient taking temazepam? Again, you might look at that and say, well, temazepam isn't even a drug that I need to know. If you're doing homework and you see this type of thing, you need to either one, try to figure out what it is based on prefixes and suffixes. In this case, PAM should clue you into what classification this medication is. And if there aren't clues, then you need to look it up, figure out what the classification is, and then try to determine the correct answer based on knowing what happens with medications in that classification. So go ahead, pause the video, think of what it might be. If you chose D, that is the correct answer. For safety, the patient would need to ask for help before getting up, especially an older adult who may have an unsteady gait when taking a sedative hypnotic. And again, if it's ending in PAM, that should be your clue that you're dealing with a benzodiazepine. Temperature is usually not affected. However, respiratory depression may occur. Temazepam is only given orally. Monitoring daily weights is not necessary, but renal impairment should be monitored. Question 2. What would indicate to the nurse that a patient taking a sedative hypnotic requires more teaching? If you answered D, that is the correct answer. Kava kava may interact with CNS depressants. Listening to music may promote sleep. Renal impairment should be monitored and adequate amount of liquid is necessary. Question 3. An older adult complains about insomnia. Which suggestion would be most appropriate for the nurse to provide as an initial method to deal with the issue? If you answered B, that is the correct answer. Before medications are used, various non-pharmacological methods should be used to try to promote sleep, including avoiding strenuous exercise before bedtime and avoiding naps during the day. Drinking warm milk or chamomile tea before bedtime has been found to promote sleep. Question 4. A patient is taking a hypnotic nightly to enhance sleep. The patient experiences vivid dreams and nightmares. They may be associated with. The correct answer there is D, REM rebound. Question 5. The most serious adverse effect of spinal anesthesia is. I'm hoping you all answered C, respiratory distress, right? Airway, breathing takes priority when we're assessing our patients. Practice question 6. Which drug is commonly used for conscious sedation? Correct answer is A, midazolam. Brand name for midazolam is Versed, if you're familiar with that. And again, you see that LAM ending, you should know that you are dealing with benzodiazepine.